Good morning, everybody. Before I begin, I must thank Dr. Vita, Dr. Nuzhat, and their entire team for looking after every detail, for chalking out such a meticulously planned scientific program, and showcasing the Stillbirth Society of India. Thank you very much. So, this workshop is all about bereavement care principles, or I would say, how to get it right when it has gone wrong. In every society, in every culture, the news that a baby is going to come into this world is a celebration. It is celebrated as baby showers. It is celebrated as God Bharai in our part of the world. Sometimes it can go terribly wrong. Let's see how many times it happens.
Problem is a huge problem. As per the latest report, every minute there are nearly 4 stillbirths. Every hour, over 200 stillbirths, and in a day, almost 5,000 stillbirths. And in a year, it's kind of 2 millions. So it's a huge problem. We can't even think of. And the globally, if we see, the stillbirth rate is 14 per 1,000 total births, but the 98% of these stillbirths are from developing world. And if you look at this, we India top this list in absolute number of stillbirths. And these first 3 countries, that is India, Nigeria, and Pakistan, there in every 3 stillbirth is from these 3 countries, and they contribute to 36% of the burden. And just imagine these countries contribute only 30% of the live birth burden. So the number is huge and the problem is very big. So we dedicate this workshop to all the mothers under our care who lost their babies before birth and faced the heartbreak of returning with empty arms.
So if you see just below the flower pots, there are instructions for you. I'll give you 2 minutes to read those instructions for image theater. Just under the flower pot, there are 2 papers. One is instructions for the forum theater, and another is instructions for the image theater. So right now, please read the instructions for the image theater. So we want a very interactive audience, lots of inputs from you people. So we will divide you into groups according to the table that you are there sitting with. Now I request you all to close your eyes and to imagine any incident that you remember where you saw a mother or a family or a healthcare worker dealing with stillbirth. So just try to bring that image into your mind, and then you can all come forwards one by one and try to bring that image here. But the rule is that you do not talk. Only with your body language, you have to portray that image, that emotion that a woman goes through, or a healthcare worker or the family goes through when a stillbirth happens. So you have 2 minutes to discuss amongst yourself. One of you may come forward, or the entire team may come forward as a group and try to project an image. And when you are ready, you can put your hand up. So what are emotions you think that come into play? The woman or her family or her husband or the healthcare worker or all of them as a whole, they are undergoing. So anybody would like to come forwards? Yes, please come. So a big clap for him. He's the first one You'd like to come here up on the stage? This way? But the rule is that you don't talk, you just have to portray that emotion or that interaction between the human beings in the form of an image. You can be there.
Myself, I am Dr. Shivashankaraya, retired civil surgeon specialist in 2013. I worked in that 100-bed hospital. There was para 1 L1 with IUD. She delivered normally because of lack of
So
staff.
we
So
want you
my-
to show the emotion first, and later we're going to talk. We'll hold the mic for you. Just the emotion. Okay. Okay. So that's it. You just remain here. Next. Anybody? Yeah, come. Big hand for them for truly portraying. I hope you'll just please stay here for 1 minute. We'll finish for a few more. Yes, a few more inputs. Yes, a few more people from the back. Yeah, doctor. Yeah, sure. Yeah, you can hear. You stay here. Because and then all the images we will together we will. Yes, next please. Any more teams coming here or person coming here? Yeah. So this image of oppression, yeah. So some positivity coming out of it. Yeah, that's the last one, yeah. So some inputs from the audience. What emotions were communicated through these images? Yes? Empathy, okay. What else? Grief, yes? Sorry? Consolation or support. Some more? Sorry? Denial, yes. Denial was there, definitely. Frustration, yes. Helplessness, yes, you're absolutely right. So aggression was missing, yes. Rightly pointed out by Dr. Manjupuri. We saw a range of emotions. We are working day in, day out with stillborn mothers, and this is what we could portray. Let's see what is actually happening to a woman who has undergone a stillbirth. And this is a small clip from the last conference we held at PGI. And with her consent, I'm going to play this clip.
बट मैं बहुत खुश हूँ कि आज मैं यहाँ हूँ और मैं ये कहानी सुना सकती हूँ. बहुत लोग नहीं सुना सकते. बहुत मुश्किल कहानी होती है एक स्टिलबर्थ की कहानी. किसी को खोने से बहुत बड़ा दुख है एक बच्चा खोना. और लोग ये कहते हैं ये बच्चा तो आया नहीं था इस दुनिया में अभी. क्यों नहीं आया था? हमारे अंदर 9 महीने से था. हमें पता है ये एक जीती जाती जान थी. हमारे लिए एक इंसान था ये जो चला गया इस दुनिया से. हमारी कंट्री में बहुत बहुत लापरवाही है इस चीज को लेके. इवन डॉक्टर्स डोंट टेक इट सीरियसली. मैं एक वेल एजुकेटेड फीमेल हूँ. आई वर्क इन अ वेरी गुड रेप्यूटेड कंपनी. एक अच्छे रैंक पे हूँ. एक बहुत वेल अवेयर पर्सन हूँ. और इतनी अवेयरनेस होने के बावजूद भी मेरे साथ ये इंसिडेंट हुआ. लास्ट ईयर की ये बात है. आई वॉज फुल टर्म प्रेगनेंट. आई वॉज फोर्सिंग माई डॉक्टर टू सेंड मी टू द डिलीवरी रूम कि मेरी डिलीवरी कर दो, डिलीवरी कर दो. इट इज़ 37 वीक्स, इट इज़ 38 वीक्स नाउ. आई एम नॉट फीलिंग कंफर्टेबल. आई वॉन्ट टू गो फॉर डिलीवरी. बट माई डॉक्टर डिडंट सेंड मी थ्रू. दे वर लाइक ठीक है एक हफ्ता और. शायद डॉक्टर्स का अपना परसेप्शन था थोड़ा टाइम देना चाहिए, थोड़ा बच्चे को ग्रो करने देना चाहिए. डॉक्टर मे वुड हैव बीन राइट. बट कहीं ना कहीं डॉक्टर की एक्सट्रीम लापरवाहियाँ भी रहती हैं इन केसेस में. जैसे कि उन्होंने ढंग से स्कैन, वो डेली ऑलमोस्ट ऑल्टरनेट डे स्कैन करते थे. बट अगर उन्होंने ढंग से स्कैन किया होता उनको बेबी का पता चलता कि कोई प्रॉब्लम तो नहीं है. माई बेबी वॉज एट 33 वीक्स 2 kgs 200 grams, and the day she was born she was same weight, and she was born at 38 weeks. What was the reason behind that? डॉक्टर की लापरवाही. एंड उसके बाद हमारे देश में ठीक है डॉक्टर ने जो किया जो मेरे साथ होना था मैं उसको किस्मत समझ के एक्सेप्ट करती हूँ. लेकिन उसके बाद हमारे देश में बिल्कुल कोई हेल्प अवेलेबल नहीं थी. कोई मेरे को आज पहली बार पता चला यहाँ पे कोई सोसाइटी भी है हमारी कंट्री में जो स्टिल बर्थ के लिए हेल्प करती है लोगों को. जीरो फैसिलिटी, जीरो एजुकेशन अवेलेबल. द ओनली हेल्प आई कुड गेट वॉज फ्रॉम UK गवर्नमेंट. टॉमी सोसाइटी करके एक सोसाइटी है. मे बी दे आर ऑल्सो हेयर टुडे इन सम लेक्चर रूम. या सो दैट वाज द ओनली प्लेस दैट हेल्प मी. इतनी अनएजुकेशन है हमारी कंट्री में इस चीज को लेके कि इसके लीव्स भी नहीं है. We get 45 days leave for miscarriage up till 3 months, and we get 45 days leave up till 9 months. What is the reason behind this? September 20th को last year ये रिवाइज हुआ है. उन्होंने उसमें 45 से 60 days किया है. What is 60 days for a mother to recover? Nothing. क्या एजुकेशन है हमारी कंट्री में इस चीज को लेकर? और इतना बड़ा टॉपिक है ये. मैंने अपनी ऑफिस में 6 months की लीव अप्लाई कर दी कि जी यहाँ पे तो लिखा हुआ है कि 6 months की मिलती है. बट दे टोल्ड मी नो, इन आवर कंट्री इट इज जस्ट 45 days. एंड आई वाज सो शॉक्ड कि इंडिया जैसी इतनी ओवर पॉपुलेटेड कंट्री जिसमें स्टिल बर्थ इतना कॉमन है उसमें लीव्स भी नहीं है. उसके अलावा अपने आप रिकवर करने का प्रोसेस, देवर नो स्पेशल फैसिलिटीज अवेलेबल. कोई साइकोलॉजिस्ट स्पेशल अवेलेबल नहीं थे, कोई थेरेपिस्ट स्पेशल अवेलेबल नहीं थे सिर्फ इस चीज़ के लिए कि हम इसके बारे में बात कर सकें. खुद से सारा स्ट्रगल करना. एंड इवन माई प्रीवियस डॉक्टर्स दे वर नॉट एट ऑल इंटरेस्टेड कि मेरे साथ क्या हुआ है क्या नहीं हुआ है. उनको देखना चाहिए नहीं देखना चाहिए. दे वर लाइक ठीक है डन एंड डस्टेड, बच्चा हो गया, आप हमारे हॉस्पिटल से जाओ, दोबारा मत आना. एंड इट इज़ अ रिप्यूटेड प्राइवेट हॉस्पिटल ऑफ चंडीगढ़. इट वॉज नॉट एनी 3rd grade हॉस्पिटल. मे बी वहाँ के डॉक्टर्स भी शायद आज यहाँ प्रेजेंट होंगे, बट इट वॉज अ वेरी गुड हॉस्पिटल. एंड मैंने फुल अपने अवेयरनेस से फुल्ली चेकअप करवाया वहाँ. बट बहुत डिफिकल्ट प्रोसेस था. आई रियली वॉन्ट कि अगर आज यहाँ डॉक्टर्स हैं तो वो इस इशू को समझें कि स्टिल बर्थ के बाद मदर्स को बहुत ज़्यादा एंग्जाइटी होती है. anxiety not just in terms of next pregnancy or next child, but anxiety generally in life, हर एक चीज़ को लेके, हर एक अपने special one को लेके, कि मैं इसको ना खो दूँ, मैं उस चीज़ को ना खो दूँ. We start considering ourselves unlucky. I used to consider myself highly lucky, कि मैं बहुत lucky इंसान हूँ, मेरे साथ सब कुछ बहुत अच्छा होता है. Since 1.5 year, 2 years, मैं सिर्फ एक चीज़ सोचती हूँ कि मैं बहुत अनलकी हूँ. कुछ होता है, मुझे ऐसे लगता नहीं मैं अनलकी हूँ, मेरे साथ तभी होता है. एक इंसान जिससे इतने साल ये सोच के निकाल रहे हो कि आपका बेस्ट है इस दुनिया में, वो अब सिर्फ यही सोचता है, at the worst on this earth.
So, can we just now make a list of all the emotions or problems related to bereavement care that she discussed in those 5 minutes? That video lasted for 5 minutes. We saw some images portraying those emotions that we think these women are undergoing. She, I think, summed up all the problems related to bereavement care in our part of the world. So can we just quickly, from the audience, anxiety, yes. Guilt and rejection, yes. Frustration, indifference, apathy, she used that word. What else? Lack of support. No counseling support, bereavement care support was there of any level, yes. Depression. Angry on the healthcare provider that she was not taken care of. What else? Not listening to her, yes. Yes, low self-esteem, insecure, unhappy with the system, yes. She was suffering from that. What else? Sense of worthlessness, yes. What else? She talked about some practical problems as well. In our part of the world, where women are not, taken care of so well, their status in society is related to whether they give birth to a child or not, and whether it's a male child or not. The moment the stillbirth happens, all those, the care that she was about to receive and the elevation in her status, that is taken away from her, isn't it? Ye khalo, drink those meva khalo and dry fruits le lo, all those things, that care that she receives, that's not given to her. Eat this, drink that, because you're going to feed the baby, no. And then the government also. You're absolutely right. She talked about not enough, maternity leave after. She has taken care of that baby 9 months. She needs to, apart from that, the physical stress that every pregnancy undergoes. She has undergone emotional trauma as well.
Sorry, I think there's a lot of pressure for women to have a baby. And she's married, and there's a lot of pressure, and now she's lost a baby. So,
She's lost.
Yes. So there's a lot of pressure to conceive.
And she's again concerned about what is going to happen in her next pregnancy as well. So we never thought of it in that manner, though all of you portrayed some very, touching images, some very traumatic images, but yes, apart from that, just look at the range of emotions that is happening in one single woman after stillbirth, and just because somebody thought to invite her there at the conference and talk to her. So this is our team. We already put our CVs on the group. You can check out on us.
So the agenda of our workshop is we'll be covering pre-workshop evaluation. We have already shared with you all. So I request you all to please fill those as early as possible, at least before starting. Breaking bad news, care of mother during labor and delivery, memory making, workup of the fetus and how to counsel parents for perinatal autopsy, acknowledging parenthood, last rites, discharge and aftercare, healthcare workers debriefing and counseling, and post-workshop evaluation that we will be sharing soon. So the objective of this workshop is, I would like to highlight here, see, we always think that the bereavement is a work of counselor or a psychiatrist, but it is not like that. There are 3 levels of care, that is level 1, level 2, and level 3. And today we are talking about the basic care, that is level 1 care, where at least we all, obstetrician, gynecologists, midwives, nursing officers, be able to provide socially, religiously, and culturally in a compassionate manner, and to be able to achieve level 1 trainers of TOTs, bereavement care provider certificate from SBSI. So now, why we are talking about bereavement? So stillbirth. Yeah, ma'am. Yeah. As I told you, in Ireland, they have divided this level of care into 3 components. One is basic care, what we are going to talk about. Level 2 care is that is being provided by the trained counselor, that is special care. And level 3 care is the therapeutic care, which is being provided by a psychiatrist or psychologist who are in complicated grief. So now, why we want to talk about bereavement? Because stillbirth has emotional and psychological impact on women, families, communities, and healthcare workers also. There is a social stigma, we just heard about a lady, intimate partner violence, loss of self-esteem, poor quality of life, especially in our setup. 25% of bereaved mothers suffer severe symptoms year after the death of the baby. And in 2016, even in Lancet, is emphasized that we should work on reducing the negative effect of stillbirths. Even WHO mentions that there should be dignified maternal care for grieving parents as a part of respectful maternity care.
So whether it is ACOG, SM, FM, everybody emphasizes on bereavement care as part of the, perinatal care. But current care for bereaved parents is non-existent, inconsistent, or it is not evidence-based. What do parents want? Yes, from the audience. I think absolutely right. The most important thing on their mind is, why did it happen? What was the cause? So that it is not repeated in future. Thank you so much. Yes? What happened to the sweets? Yeah.
They also want how we can prevent it, whether it will recur in the next pregnancy, same kind of events.
Yes, they
That
want
is
to
the-
know what is the
yes.
risk of recurrence. Absolutely.
How we can prevent it
Okay,
occurring in
yes.
the next pregnancy.
What else?
Family support.
Family support. Somebody said family support. So I'm very happy that you gave that answer coming from a husband, not a patient, because most of the time we are focusing on the mother. Okay, yes, the family also needs support. Yes, what else?
Support from the healthcare workers, like respectable maternity care is less for these people who have IUFD, like they want to examine them in the labor room frequent times, how they examine a woman with the live fetus. So during that time, they feel very much neglected. In hospital, also, the care has to be
Yes,
proper.
very true. Yes, any more inputs? So we did have a few answers regarding what do parents want,
Sorry, also,
but
they also want to be.
actually, this is from your experience that you're talking about. But we do not have answers, because the need is different for different women coming from different cultures, from different societies, from different religions as well. And we have no answers. Why? Because there is absence of high quality RCTs. Scientifically rigorous clinical trials are difficult due to a small sample size and the very sensitive nature of the event, and hence there is a dearth of data. So we do not have many answers. We do not have many scientific answers of what should be done as part of bereavement care. It was in 2016 that despite the impact of stillbirth, which has impact on both the parents and the staff, that the healthcare workers, we found that most of the healthcare workers received little training or inadequate training. Then it was in 2019 in the British Journal of Obs and Gynae, a meta-analysis was published which said was the first synthesis of evidence of bereavement care in the low and middle income countries. So it included 34 studies from 17 countries which identified 13 themes, and it was done by Shakespeare et al. And these 13 thematic elements, which were unique to low and middle income countries, the most important was that bereavement care should be tailored to socio-cultural context. It cannot be the same for all societies, for all women. In response to Lancet's call for a global consensus on bereavement care, the same group of authors, collaborating with many other authors, brought out the Respect Working Group, which defined 8 important core principles of stillbirth care. So this is the Respect study, which basically consists of final principles of, which includes these points, that we need to reduce stigma experienced by bereaved women and their families, provide respectful care, support women and families to make shared, informed, and supported decisions about birth options, make every effort to investigate. I'm glad you all realize that this is the most important question for the parents. Acknowledge the depth and variety of normal grief responses. Offer appropriate information and postnatal care. Provide information for women and their families about future pregnancy planning, and enable the highest quality of bereavement care by providing comprehensive and ongoing training and support to all the members of healthcare team. So now the question is, what is the right way of doing it? And again, another question is, do we have a standard evidence way of doing it? Or should it be done in the socio-cultural context? So again, we have no answers or only a few answers, especially for our part of the world. So the rest of the session is based on these resources and a review which was published in May 23. And we will see how we can get it right when it has gone wrong. But it has to be inputs from all of you so that we also arrive at a consensus. So there's a bereavement care pathway or bundle. So do you agree that I should call it a pathway or bundle, which is activated on stillbirth diagnosis? Anybody? Would you like to call it a pathway or a bundle, or because it means something uniform, universal that you are offering to all women? So I put it there just to emphasize that it cannot be uniform or a standard way for all women, but yes, we need to work on it and provide the best to that particular woman. So that was put there just to emphasize that bereavement care cannot be uniform for all women. Women react differently to grief. They have different needs. Different families have different needs. So keeping that in mind, we'll follow certain rules, and then the first being respectful and sensitive communication and support for the parents. So now again, we need your participation. We are going to give you a scene, show you, and can you just take out the second paper that is there, instructions for the forum theater. So again, you work in groups, and just watch the scene. And once you watch the scene, you all have some idea of what can be a wrong way of doing things and what can be the right way of doing things, isn't it? So we will just give you a small scenario. You observe it. You have some oppressed person there. You have oppressors there. So if you would like to stop this scene anytime, you can just say stop and come here and play the part of that oppressor in a different manner. Are the instructions clear? You just see what is happening here. If you think that something is wrong, just come here and act the part in your manner, what you think is right way of doing it. Okay? So this is a scenario in a busy labor room, and a lady is coming here she's almost term, the doctor is busy, just see the interaction, and then she goes and interacts with other doctors as well. So if you have any idea of doing it in a different manner, whether for the oppressor or the oppressed, just say stop and come here and do that part. So just see the scene first.
डॉक्टर साहब नमस्ते, मैं सुनीता।
अच्छा,
डॉक्टर साहब सुनो, डॉक्टर साहब मेरा
नर्स,
बच्चा नहीं घूम रहा।
नर्स, उस पेशेंट
डॉक्टर
का
साहब
क्या हुआ?
सुनो
वो
तो
जो
सही।
पेशेंट नंबर 2 था,
आप बोलो ना
उसकी
जी,
फाइल
बोलो, सुन नहीं रही डॉक्टर। डॉक्टर साहब सुनो तो, प्लीज सुनो, मेरा
हाँ,
बच्चा
क्या?
नहीं घूम रहा।
अरे यार,
अभी घूम रहा था सुबह,
इतना
2
सारा
घंटे से
लेबर रूम
नहीं
में
घूम रहा।
ठीक है, जाओ। एक बच्चा
डॉक्टर
नहीं
साहब,
घूम रहा
आप
ना तो
देख लो एक बार डॉक्टर साहब।
अरे बच्चा नहीं घूम रहा तो अल्ट्रासाउंड करा के उसके बगैर कैसे पता चलेगा?
कहाँ जाऊँ अल्ट्रासाउंड?
अल्ट्रासाउंड बाहर इतने सारे सेंटर है यार, कहीं जाके करा लो अल्ट्रासाउंड।
चलो चलो जल्दी चलो जी।
Just, can we just complete it? Then you can, yeah. Complete it once, then we will replay it.
डॉक्टर साहब मेरा बच्चा नहीं घूम रहा। डॉक्टर साहब मेरा बच्चा, प्लीज।
The mic, yeah.
क्या हुआ?
वेट करो माँ, देखेंगे। क्या जल्दी है? अच्छा नहीं, जल्दी जाओ, अपने डॉक्टर के पास जाओ।
मेरा बच्चा बच जाएगा, मेरा बच्चा।
जाओ
डॉक्टर
जाओ,
साहब,
जल्दी जाओ,
कुछ तो बता
डॉक्टर
दो,
के पास
डॉक्टर
जाओ, आपके डॉक्टर बताएंगे।
डॉक्टर साहब, कुछ ठीक
अल्ट्रासाउंड।
नहीं लग रहा। देखो उन्होंने बोला।
अरे बताया नहीं अल्ट्रासाउंड वाले डॉक्टर ने, तुम्हारे बच्चे की धड़कन नहीं खत्म हो
डॉक्टर
गया
साहब
बच्चा?
ऑपरेशन कर दो, घूम रहा था 2 घंटा पहले, प्लीज निकाल दो
अरे,
बच्चे को, कुछ तो करो डॉक्टर साहब।
अरे बच्चा
मेरा
खत्म
एक ही
हो गया
लड़की है
है
पहले डॉक्टर साहब, मेरा
कम
बच्चा
से कम
पूरे
2 दिन
टाइम
का बच्चा खत्म है।
अरे
अब आइयो, तुम सो रही थी क्या?
अभी भी घूम रहा था जब मैं वहां गई थी डॉक्टर साहब।
कैसे
ऐसे
घूम
ना
सकता है
बोलो।
खत्म बच्चा? अरे सुनो, अच्छा
अरे
चलो
नहीं,
उधर
घूम
जाओ।
रहा था, घूम
जब
रहा
मैं
था।
कहती थी कि घूमो मत, ये खाओ वो खाओ, तो ये होता था कि पुरानी बातें करती।
अरे नहीं, मेरा बच्चा ठीक होगा डॉक्टर साहब, प्लीज कुछ तो करो डॉक्टर साहब, प्लीज कुछ तो करो।
शाम को घूमने जाती थी, सुबह में चाट पकौड़ी खाती थी।
मैं क्या करूं अब, मैं क्या करूं?
ओके, थैंक यू।
So we are playing it again. If anybody wants to say stop, playing it again. Want to come and replace any one of us? Please come and do it the right way, whatever you think.
नमस्ते डॉक्टर साहब। डॉक्टर साहब नमस्ते, मैं सुनीता, मेरा बच्चा नहीं घूम रहा डॉक्टर साहब 2 घंटे से। डॉक्टर
सिस्टर,
साहब,
वो पेशेंट नंबर 2 का जरा बताना।
डॉक्टर साहब दो
ओके,
प्लीज नॉट। मेरा बच्चा घूम रहा था मैडम, सुबह से तो घूम रहा था, बस 2 घंटे से नहीं।
मतलब थोड़ा देखेंगे। हाँ, देख रहे थोड़ा, ये तो लग रहा है कुछ, आप चिंता मत करो, थोड़ा एक बार अल्ट्रासाउंड एक बार देख
ठीक तो
लेंगे।
हो जाएगा ना सब?
नहीं, देखेंगे बेटा, इतना चिंता मत करो। हाँ, थोड़ा सा कुछ लग रहा है तो एक बार अल्ट्रासाउंड
कर दो मैडम।
हाँ, थोड़ा देखने के बाद कर लेंगे, चिंता मत करो, ठीक है? ये हम ट्राई करेंगे, पहली बार एक बार अल्ट्रासाउंड में कंफर्म कर लेंगे, फिर इसे थोड़ा कुछ ये लग रहा है मुझे, ठीक है?
बहुत बहुत
हाँ,
धन्यवाद
एक-
मैडम आपका। क्या लेना मेरा बच्चा? डॉक्टर साहब, मैडम ने अल्ट्रासाउंड के लिए 2 घंटे से ना मैडम। नमस्ते मैडम, मैं सुनीता मैडम। मैडम बच्चा नहीं घूम रहा था, मेरी मैडम ने भेजा है मुझे।
1 मिनट, देखेंगे क्या है।
एनीवन वांट्स टू स्टॉप एट दिस पॉइंट?
मैडम
के पास जाओ।
बता दो मेरा बच्चा ठीक
बच्चा
है
अच्छा
मैडम?
नहीं माँ, डॉक्टर के पास
Stop,
जाओ,
stop,
दिखाओ।
stop. स्टॉप।
मैडम, मैडम मेरे को मैडम दूसरी मैडम ने भेजा।
Yes, please be quiet. Nicely lie down. We'll show you. Because I'm not very fluent in Hindi. May I speak in English? Yeah. समझ आता है. देख लो, that is the monitor. Hi. So you see that your baby's head. Are you me? Yes. Just see, watch. Okay.
And see, this is the spine, this is the thorax. Can you see the fetal heart there? Is it beating or is it stopped? Yeah. So are you feeling the fetal movement? Today? Past 24 hours? Okay. So say the now we are not seeing it beating. And anything you had? Rupture of membranes, bleeding, kuch hai? Okay. So you can see the rest of the baby. So this is a clinical scenario of stillbirth, I understand? Yes. So we don't know at present why the fetal heart is not there. Mat karo. We'll find out the cause. Okay. And the placenta is appearing, it is calcified, thick. You can see that. So we'll find out the cause, and I will give the report to your doctor, and your doctor will explain the reason.
Dr. Manju wants to stop.
Want to say is it is also important to show the pictures of the baby to the mother, which the radiologist will not always do it.
What's your name? All right. So okay, let me restart. This is my way. Each one of us has different ways, but I introduced myself, and I am Dr. Nuzet Sunita. And I believe you have come with a complaint of decreased fetal moments. Can we just check, do a little ultrasound and take a look at it as to how it is? So I do a scan, and Sunita, I think there is a little problem. Okay, we would like to read, scan, get another person also. If I have a colleague, I will usually have them as this thing. And it doesn't look good, Sunita. Is there anyone with you?
Dr. Bharti, Mike.
Yeah. I totally, understand.
Mike, Dr. Bharti.
So we are not able to see the heartbeat, Sunita. They usually understand. Sometimes, if they don't understand, is my baby dead? They will ask, and I usually say, yes, we are not able to get the heartbeat, and that is the diagnosis. Usually, you have. This is my way. I'm sure any one of you can stop and come over and maybe show a better way. One of the most difficult things to do. Most difficult things to do.
Why that sonologist was not ready to give the, you want to, somebody wants to come, mother-in-law? Do you want to replace?
Right.
आपको वहाँ पे करना है ना? अभी शुरू, we'll start. You can just take a seat meanwhile. Yes. Ánitha, you have to be there. Acha, you're coming back for the news. Okay, come. Okay, bring her with the report. Given to the, okay. Okay, so she didn't bring the news.
I'm crying.
There. I'll take it. Okay. No, they have the report, na? She just gave the report, that's all. Okay. The initial scenario. Oh, you want to move forwards. Okay.
अब क्या होगा? अरे मम्मी जी मुझे नहीं छोड़ेंगी, मैं क्या करूं?
मम्मी कुछ नहीं।
अरे आपको नहीं पता।
आप पहले अपना
क्या हुआ मुझे बताओ. What happened? Tell me. Why are you not telling me the news? What is there in the report?
Anyone wants to stop?
Why are you not telling me the report?
मम्मी जी वो
मैंने ध्यान रखा था मम्मी जी. सुबह
No,
घूम रहा
you
था
did not take
बच्चा.
care of yourself. You never listen to me. You all think that I am old, that's why I don't know anything.
ये सब बातें बाद में. अभी हमें सुनीता का ध्यान रखना है. हम पहले डॉक्टर के पास.
Karo judal chai, whatever, do whatever you want. Anybody wants to
Anyone
replace
wants to replace the mother-in-law? Anyone?
and the patient?
Or the patient? Yes.
Nobody has the guts.
Nobody has the guts.
Very aggressive mother-in-law, yeah.
डॉक्टर साहब
Hmm. Yes.
वाइफ है सुबह भी आपके पास आई. सुनीता बैठ जाए. और बहुत
This baby is already dead and the baby has been dead for 2 days. Now you're coming right now.
आप कैसे बात कर रहे हैं? No, I think somebody would. डॉक्टर साहब ये मेरी वाइफ सुनीता है. ये सुबह आई थी और तब बताया था कि बच्चा नहीं घूम रहा. फिर आपने अल्ट्रासाउंड के लिए भेजा था और ये रिपोर्ट है कि शी इज़ वेरी अपसेट एंड प्लीज़ लुक आफ्टर हर and tell us how to go forward. सुनीता प्लीज आप परेशान ना हो. अभी डॉक्टर साहब
I'm sorry, Ánitha. We are really sorry about it. You know, there are so many things which are not within our control. Really. No, we all understand that you've done your bit, no? We'll. Don't worry. Move. Look at.
I hope it is safe.
Yes, don't worry. As if we can't get the baby back, but well,
But
will
she
be.
should be okay. She
Positive,
should be okay.
positive. We'll take full care. Ánitha, you're a brave girl, right? Yeah. Right.
You, ma'am.
So, yeah, you have to start. He's the doctor. Start the scene again. You want to be here, no?
नमस्ते डॉक्टर साहब.
Hello.
मेरा बच्चा नहीं. चाय पिया था डॉक्टर साहब. बड़ा काम होता है घर पे.
Please,
चाय पिया.
they were requesting to talk in English. Yeah.
I had tea in the morning.
This is आपकी second delivery है.
Second baby. I have one daughter. Sir. My baby was moving in the morning, but now it is.
Suddenly.
Yes.
और क्या प्रॉब्लम है आपको? कुछ शुगर वैसा बोले तो डायबिटीज वैसा तो?
No, डॉक्टर साहब. I got all my tests done and everything.
सब बच्चा ठीक है ना?
अब देखना, अभी देखेंगे. अब मेरे ख्याल से वैसा है. नो नीड ऑफ इमीडिएट अल्ट्रासाउंड. वो फीटोस्कोप से भी दे सकते हैं और फीटल डॉपलर से भी देख
do it
सकते हैं.
fast. I want my.
No, definitely. To lay down first. You should be comfortable. And when in the left lateral position, you take sleep, and at the same time we'll see with the fetal Doppler whether the heart is there or not, or simply by fetoscope itself. Then we will arrange for you ultrasonography. And as per the previous reports say
So
that
we are not, we are just, you have to do it.
yes,
Rather than talk. Yeah.
yes, we not,
Because it's a theatre.
and we will see the whether it is LOT or ROT and below molecular level, and we will see that fetal heart, and if it is found, well and good. Otherwise, immediately we will go for the Doppler for second
Anyone wants
opinion.
to stop?
And
Anyone?
So anybody wants to take the challenge of, replacing the lady, the patient, and just try to, tell us some way of negotiating that block that is there. The doctor is not listening. What we tell our patients, especially in the antenatal clinic, in the book patients, how much care the doctor will take of you ultimately also depends upon you. It's a two-way relationship, isn't it? So how to negotiate that with the doctor, that please take care of me. So anybody, a challenge for the audience. So that busy doctor who's like, okay. Who has volunteered?
Ma'am,
And
have you volunteered?
one more, some midwives I read literally means with wife. And that is why, patients are happier with midwives. They have a more human way of doing things. And I would also request, some of them are here. Fernandez is so lucky. And if they would like to do this forum theatre for us,
as per
their way of doing it.
gestation, term.
So thank you so much, Dr.
This is what is happening in the rural area. And when I was telling about the previous LSA, it was admitted in our hospital. And the baby was small. Previous one was good enough.
Husband?
And I did about 2-3 cesarean sections at the government level.
Husband.
In the government hospital. So she suddenly delivered a IUD.
Want a husband?
Oh.
So the, what you call, we have to face the problem with the media people and the
So
local
you didn't
leaders.
know you had to take out a cesarean, a stillborn baby through a cesarean. And you didn't know because the sonography
Yes.
Sonography was not available at the periphery.
Suddenly they came
Yeah,
as
it's
an
really
unbooked,
challenging to work,
unbooked
in
case.
such kind of situations. Yeah.
And other thing is, even our staff nurses or midwiferys, they never bothered to detect fetal heart.
So that is lack of training, yes.
But I gave
There
training.
should be set protocols, what to do exactly when a patient with decreased fetal movement is coming.
So I trained them for conducting a normal delivery. In that way, though it is a previous LSCS, it was delivered normally. And for the live child part of it concerned, and the media and other people insisted for money and other things. So that is what is happening.
So that is one part of bereavement, inappropriate bereavement care.
We are so worried.
Doctor,
Oh my God.
I think I really need help.
Thank you. Hello, my name's Layla. I'm a midwife. How are you?
Lela, I am really worried. My baby has a certain way the baby moves every day. After every meal, I know my baby moves.
Our baby hasn't moved. The pattern is changing.
Yes.
I'm really worried.
And we've been trying to nudge the baby. I sat quiet, I relaxed. I did everything to get my baby, give me an high five, but my baby's not moving and I'm really worried.
Okay, so first of all, can I just ask, so your normal patterns of movements is when are they normally there?
Usually,
When he hears my voice in the evenings.
Yes. And after I have had something, I know my baby moves after a meal. Yeah.
So those patterns have changed
Yes.
for you?
It's just reduced. I don't feel my
When
baby.
was the last time you felt the baby?
I think it was early morning. Yeah, I felt I should wake up and have some snack, and I did. And then I was about to go to bed back again, and I felt the movement then. And now it's afternoon, and I haven't felt my baby.
Okay, so it's been enough. Can I ask you to sit down? What we're going to do is we're going to have a feel of your tummy. Okay, and we're going to listen for the baby's heartbeat.
I'm really worried.
Okay, it's
Lala.
okay. No worries. Let me come down here.
okay.
Anything else? Are you in pain anywhere else?
No, there's no pain.
No pain. Any waters or any bleeding?
No.
Okay. All right. Now listen with the Doppler. So at the moment, I can't find the baby's heartbeat with the Doppler, so we're going to take you for a scan.
Okay.
I'm very sorry.
Really worried.
Let's take you for more tests, okay, and we'll find out. But I'm here to support you. I'm not going to leave you. Okay, I'll follow you all the way through.
Okay.
We're going to
hope-
have to scan today.
We're going to go for the scan right now.
Thank you.
We're going to go for a scan right now.
Yes. The doctor's going to be available for me right now.
We're going to take you there.
Okay.
But I'm not going to leave you.
Thank you.
Thank you.
I'm sorry. So thank you so much for all those interactions and your inputs. So basically, whenever we are dealing in day-to-day life, sometimes we are oppressors, sometimes we are the oppressed, and unknowingly in both the ways, in both cases. The focus is on transforming the situation for the oppressed by taking action. The goal is not just to solve the problem, but to explore different possibilities for more respectful and humane interactions. So that was the aim for us. And this was an experiment, this was a safe space, but real life situations are not like that. You remember that example that doctor was giving, working at a PHC, the media was involved because there was no sonography to confirm that it was an IUD, and IUD stillborn was delivered by a cesarean section. So I hope you all noticed how the outcome was different because the intervention was different in all those cases. Because the oppressor changed to somebody more empathetic, who could communicate things in a better manner. And also the power dynamics that shifted. And though we did not see many new norms because nobody came and did it in a bad way, everybody knew the correct way of doing it. So the last point, that we did not find new ways of oppression there, because some doctor might have come and ordered more, unnecessary investigations. So that is also oppression in another way. So the respectful and sensitive communication, the psychosocial support for the parents, Dr. Ayesha is going to take over from here.
Thank you, ma'am. We've already seen the forum theatre, and we've already seen what should be said to the patient in different ways. So this was a point of discussion, but I'm sure that all of us have understood. These are the things that I'm going to take up. What should be said, who should say it, how should it be said, and we have different models of breaking bad news. So different things, what goes in her mind, what goes in the mind of a lady whose baby is not there anymore. One of the most important things is, they fear labor because it's painful and it's without reward. I have worked in many government hospitals, and I'm telling you that pain relief is really something, at least in my part of the country, we are really not very much into pain relief. We don't give epidurals in government hospitals, and the pain relief that we offer is really just maybe Buscopan, which tramadol, which hardly does anything. And especially those women who are laboring with a stillborn baby, they know that it's a baby who's not live, and they're not going to get any baby after that labor. They need to be really taken care of, and especially with regards to pain. They may feel guilty of not taking enough care. They may be angry at the doctor. And yes, these questions, why me? Is it a punishment for my sins? Because, sometimes we took a survey, and a lot of women, they came up with that they were told, in the last in the last 1 month, you were walking in the evening beyond, beyond dusk, and that's something, really not acceptable. Maybe you didn't pray enough, maybe you didn't eat enough, maybe you didn't rest enough. And breaking bad news is something not part of our PG curriculum. It's been recently introduced. We're still working on it, how to teach our residents how to break bad news. Something we've learned with experience, but then training always helps. So we have different protocols, and I'm going to discuss the Spikes protocol of breaking bad news. First of all, where are you going to break the bad news? Please ensure privacy of the patient. Please involve both the parents. Like we saw in one interaction, I think Dr. Nuzhat, she asked, is there someone with you? Where's the husband? And, that kind of let's say a setup, it's, you're delivering a lady in a labor room where so many other women are there who are going to have live babies, and that's the place where this lady is going to deliver. That's a very, very distressing situation. Also, once she's delivered and you've shifted her to the same ward where there are so many other mothers holding their babies and she doesn't have any baby, that's a very distressing situation which we need to take care of. And yes, like we're working in a busy hospital, we have our time constraints, so you cannot devote an entire day to break bad news. You have to manage your time and you have to say whatever you want to say effectively. And please ensure no mobile phones, no interruptions. It's really very bad, to tell a patient that your baby has died while you're eating a pastry in the labor room. That's really not done. Okay, the next thing is, first of all, please determine what the patient already knows. Maybe the ultrasonologist has already told her that it's a dead baby, and she already knows that. So it's important to know what is a level of comprehension. And then there are some women who will say, I don't want to know anything more about this. And there are some women who would like to say, no, I want to know why my baby died. So you cannot have a bias as to this is the proper way a woman should behave. Everyone behaves differently. And I can tell you from my personal experience, so 2 of very close family members, one my sister and one my sister-in-law, both of them had stillbirths. My sister, she had a stillbirth. It was a 3.5 kg baby, firstborn. And, like this lady was saying, well educated. So my sister, she MD radiology from AIMS, first attempt, always a good student. And then she went to a corporate hospital, a very well-known corporate hospital. She had cord prolapse, and it was a dead baby that came out, 3.5 kg male baby, dead. So it's a male. In our part of the world, male is very important. But then, now, she wanted to know. She wanted to look at the baby. She wanted to hold the baby. And then I had my sister-in-law a couple of years later. She had a stillborn baby. She didn't even want to look at the baby. She didn't want to hear about that baby. She didn't want to know the news. So it's the patient's right. I cannot, decide her right. And we come to SPIK, the K part of the Spikes protocol. Then you give the facts. You have to avoid simple language, avoid medical jargon. We've already known, it's been told to us when we talk about history taking, examination, right in our MBBS days that take history, please avoid jargon when you're presenting the history. Okay. Consider the educational level. So, someone who's well educated and someone who's totally illiterate, you cannot, just tell an illiterate lady, you have to use the local language. So like we talk in Hindi, and suppose there's a lady who comes to us, totally, a villager, an illiterate. So I cannot just talk in English and say, you have had an IUD. That's not done. How do we actually break the news? So like Dr. Nuzhat said, and like we saw in that beautiful presentation presented by the team of midwives, that, I'm not able to see the baby's heart. I'm really not sure that all is well. I'm sorry, we've detected a major problem, which I need to tell you about.
Shall I interrupt you, ma'am?
Okay.
Yeah, I have a doubt about the sorry because we had a meeting for this PVI toolkit we made in PGI Chandigarh. And there was a confusion that in our region, if we say sorry, it means that we have done something wrong. Like we are going to meet a patient and we are saying, I'm sorry, you are carrying this thing has happened. It looks like that, like we are, we are asking her that we are sorry that this thing has happened. So it's very difficult. I don't think so in India, the sorry word is the right word to start with.
So how many of you agree that we should not use the word sorry? Because many of us misuse that word. Sorry doesn't mean that you are sorry or you did that mistake. And there's evidence for it. This has happened. Sorry means we are with you. Yeah. So you are right, Bharti, you are right, yeah.
Like we in our language, we say, मुझे बहुत अफसोस है, मुझे
Yeah.
दुख है, ये हुआ, So that's also sorry actually means that.
That, yeah.
Sorry means like, I'm sorry this has happened, for you. I'm sorry.
I'm with you or मुझे अफसोस है.
It doesn't mean that
means-
it was my mistake.
So, yeah, I think you made a very important point. Dr. Manjush says that it has to be appropriate in the social, cultural context. So whatever language you are using, you have to be very careful. What Bharti's experience is, again, from some workshop, where they decided that they will not use the word sorry. I've been using it, but I think Ayesha was also right that it means कि मुझे अफसोस हुआ. And what Dr. Richa said
कि
also,
मुझे
yeah.
दुख हुआ rather मैं माफी चाहती हूँ. If you
We don't
translate,
use
I'm
that
sorry.
word. Actually, Bharti, we don't use कि मैं माफी चाहती हूँ. We are sorry to inform you, yeah. So if you want to talk in English, you can say we are sorry to inform you, yes. That will be slightly different, yeah. Yeah, absolutely right. So somebody's taking the note. Just write it down, yeah.
Yeah,
And
I think
So there
the
was this discussion on this, yeah.
I think the thing saying sorry is definitely in context of I'm sorry this has happened to you. The women, the families that will come back and say that it's our fault are going to come back and say it anyway because that's part of the grieving and processing of it all.
So you're talking from experience, absolutely right, yes.
So the next part of the protocol we've done with SPIK and is, you empathize and please allow denial. Suppose she says that, like a patient was saying that I'm still perceiving fetal movements. So you cannot just negate that and say, oh, the baby is dead. How can you perceive the fetal movements? You can offer her a repeat ultrasound if she says. And listen, because when people talk, listen completely. Most people never listen. So just some examples that suppose a patient comes, I wouldn't like to say, suppose I say, I know what you're going through. And the next thing she might say, really, have you lost a baby? How can you know what I'm going through when you haven't lost a baby? A better way would probably be, I cannot even imagine what you're going through. Then I can feel your pain. So she can come back with, you haven't lost a baby, you cannot feel my pain. So you can probably word it like, I cannot even imagine how painful it must be. And again, I'm sorry for you. Instead of that, you can probably say, I'm sorry to hear that. It can be more, rather than being condescending. And then you have to close the interview, you have to, summarize, and this we're going to discuss how we're going to present the plan, how we're going to tell her what next we're going to do, and provide written information. That's very important, which we really don't do. I don't think any of us are doing in government hospitals, at least, provide written information. And one important thing that I would like to say at this moment, just one thing, is when you're breaking bad news, please take the socio-cultural context, because like we get so many patients from villages, right? And you're explaining everything to the lady, and suddenly, after you've explained everything, she'll say, I'll go and call my husband. I'll go and call my mother-in-law. And sometimes they might get aggressive. So please also take protection for yourself when you're breaking bad news for anything, especially for stillbirth. And now Dr. Tamkin will take over from the next slide.
That's what I want to say, taking a break for tea. But before that, I just wanted to show you this slide again, Ayesha slide. You saw what we thought that the woman is going through that image theater. And you saw the difference, what the woman was actually going through. So we cannot even imagine what they are going through. is what we should remember. So the rest of it, we will do after a break, short break for tea. So welcome back. So this is for the PGs, postgraduates who are here. I hope they will remember this photograph all their lives. When a baby elephant dies, the other elephants circle around her, giving her time to grieve. So the point is that we should feel the pain. And how do we convey to the patient that we are with her in this time of grief? And that is to be with her, as simple as that. So remain with the couple, answer any questions, do not begin a lengthy discussion of possible causes. Simply sitting in the room during labor is supportive and caring, as evidence proves it. The next step is management of labor and ongoing physical care to the woman, and Dr. Ánitha takes over from here.
Thank you, ma'am. So next, I will be taking to my most important aspect, that is management of labor and ongoing physical care to these women.
This is one actual sentence that the patient used, recently with me in the labor room. She was carrying a intrauterine fetal death had already occurred, she knew. And then I entered the labor room, she said, कोई तो मुझे देख लो, please somebody see me. शायद आप लोग मुझे इसलिए नहीं देख रहे हो क्योंकि मेरा बच्चा जिंदा नहीं है. You are probably not looking after me or examining me again and again because there is no fetal heart. So that is what she said.
So how to prepare these women for labor and birth? So as we all know, stillbirth is a highly distressing event for the families and the parents. Then as a health worker, what is our role? How can we reduce the impact of the trauma? So it's very challenging for the health workers to manage and to give the care of these women in labor. But it is a privilege for all our care workers, healthcare workers, to have this provision to give them compassionate care. So the care a family receives at the time of loss can have a significant and lasting impact. Yes. The parents or the families who has gone through this stillbirth can relate so much, whatever the incidents happened during this stillbirth, so long, short term and also the long term. So as a healthcare worker, what we can do is proper communication that will help not to reduce the pain, but at least the impact of trauma can be subsided. So how to prepare? Discuss first the birth options. What are the birth options? Expected management for few days, induction of labor or cesarean section depending upon the conditions. Explain clearly, sensitively and effectively. Be clear in what you are talking and do not use lot of medical language. Parents might ask for cesarean section due to so many reasons, but explain them pros and cons, whatever is best, we have to tell them. Give them some time, let them think, and then respect their choice. Give the option of going home and coming back because they are not prepared. Parents may also wish to consider things that they might like to bring to the hospital. So choosing between the vaginal birth and cesarean section. As all we know, vaginal birth is safer than cesarean section. Cesarean section only for obstetric indications like abruption and any other deranged parameters, eclampsia kind of situations. But how to birth is the couple's decision. Explain clearly about the induction process, how much time it takes, what are the methods you are going to do, and respect their choice. Whatever they opted, please go. Don't force them. Coming to the pain management, this is very, very important. Women have different experiences of pain during the labor and birth. Many women may not expect the pain, what they are going through, and may not expect the duration of labor. They are not prepared. So discuss the options of all the pain relief, including Antonox, sedatives, And of course, epidural analgesia. We don't want them to go through a lot of pain. So recommend epidural analgesia whenever it is required, irrespective of the gestational age, at 24 weeks or 28 weeks, if you have an option of epidural analgesia in your hospital setup. Coming to the place of care, where you want to birth these women. So I want to ask you all.
Sorry to interrupt you in between, but I would like to ask the people from, is there any role that we should not sedate the mother of stillborn? I have read a study where they found that those are the special moments where that stillborn mother wants to feel the baby, because after that she's not going to get that baby. So do you people, what is your experience? Do you people prefer sedation or not? Because in our place, most of the people, they prefer to sedate the mother. So what is your practices?
Hi. No, we wouldn't sedate unless it was an extreme emergency of mother was very unwell and she needed a GA cesarean section. But we don't really go for cesarean section either. We try to not force, but recommend vaginal delivery. There was a huge study done in the UK regarding bereavement care pathway, national bereavement care pathway, and women, they interviewed a lot of families that had loss, and one of the things that came through from women was that they wanted to actually birth the baby and to have recognition that even though the baby wasn't alive, but to actually have all the same things that went on with that. The point of that, where obviously if it was before 24 weeks, we still give a birth certificate, even though it's not a legal document, but it was a recognition that she had the birth and that this was her baby. So that's why we wouldn't necessarily offer sedation at all, because women want to go through that experience.
Which says that women, some women may not prefer sedation or liberal pain relief.
No, lot of here in our hospital, when they want a lot of pain relief because they go through a lot of pain, right? So whether it is sedation or epidural, most what they want is pain relief. Whether you sedation, morphine also, they are okay with it, because the pain what they're going through of losing a baby and the pain what they're bearing, they don't like it. So 90 to 95% of all my patients, they prefer analgesia.
So I also believed in, liberal pain relief, but now maybe we need to do some research on this part. Okay.
I think we should not mix up pain relief with sedation. I guess when we talk about pain relief, that is desirable and it should be given. And sedation, I think when Bharti is referring to, it is kind of making them a little drowsy so that they do not remember the things as well. So that was the point which was made by someone who had just given, that they want to want to feel what is happening around. They don't want to forget it, right? I'm to say they want to go through that process, but pain relief should be mandatory. And say it is no reason why they should be allowed to have pain. So I think we should not mix up on those two things.
But I also feel that it's individualized because every woman is different.
Yeah, I agree. Pain relief should be given, definitely. Because
it should be individualized because some women may not want the option. So are we just sedating them so we feel
not
better?
Sedating, pain relief, analgesia.
Yeah, agree, Indy. We should individualize.
No, we feel whatever she wants has to be given.
Yes.
Okay, it is very important. No mother would say, put me to sleep. Woman will ask for, I want pain relief. Even if it's 22 weeks. Okay, whatever. Let me know if you need help. Anytime you need help, we are there to support you. So whatever, different perspectives. I feel whatever she wants.
Okay, so it's her choice. How many of us are doing, can you just raise their hands up? Pain relief? Okay. Pain relief. And sedation?
Public hospitals and a newly diagnosed stillbirth in the labor room, especially intrapartum stillbirth, not at delivered, they'll be very anxious, restless, non-cooperative. In that case, we can go for sedation.
Okay.
Yeah. Yes, please.
In fact, ma'am, what is it is not a a surprise is that most of the times the patient's relatives, what they expect us is not to break the news to the patient herself. I mean, say if it is a stillbirth, or a baby, an intrapartum, so they would like the news to be confided from the woman, not to tell her. In due course of time, they would maybe find a reasonable time and then to break the news. So what is your take on that?
We'll be coming to that.
Yeah,
Thank you
right,
very much for
right.
that
Okay.
question. Okay.
Now, can I just say, I think our language is also very important because women are grieving. Let's put ourselves in their shoes. How are they feeling? I think it's a very sensitive time, individualized time, and, women are going to be in a lot of pain and her behavior may be different, but it's not because she's not cooperating. She's going through grief and expressing it differently. The question here as well is, there's a big debate, like what my colleague Leila has said. Women who have a loss back in the UK, we try to get them to have a vaginal birth because having a cesarean section scar is so obvious and it brings back those memories. I'm not sure what happens here.
We also do the, as per the indication only. We don't offer them cesarean right away, but as per the indication, we manage our patients.
Only for obstetric indications.
So coming to the place of birth. So where you want to birth these women? So do you have any at your places, any special rooms for these bereavement rooms kind of thing? Just want to know.
So anybody has a separate labor room for these women?
So can I just say, we don't have, like we've got a labor room in our first unit in Abbott, but what we do is we have a quiet corner away from everybody else. So in the moments of a woman that's experiencing a stillbirth, she doesn't hear another baby cry or another birth. But it's good practice to have an enabling environment from her that some create different spaces like where we work back home. But I think there is a need to identify a quiet space and it doesn't look so medicalized as well.
It also depends upon what she wants. Some mothers wanted to birth in the doctor's care or midwife-related care, but ideally it should be the collaborative care. So both midwife and doctor should give the continuity of care. So which we have privilege at Fernandez Hospital. Yeah.
We feel that is mandatory. The place should be separate.
Yes.
And the room where she is shifted after the delivery also should be at a place where she does not hear the cry of the other babies. In our hospital, we have 2 rooms which are away from the regular routine rooms. So even though the patient initially is placed in the regular rooms, we make it a point that she is shifted to those rooms so that she does not go through this pain.
Yes, doctor.
Really good, yeah.
So coming to the place of care is already discussed. It is distressing to give birth in a place where live babies are being born or they can hear the sounds of crying babies. And they need privacy and comfort. We can give that at least. So it doesn't mean that you should have luxurious bereavement suites kind of thing, but whatever the resources available at your place, one room with all the comfort we can give. It is a beautiful idea that, the mother has gone through so much. From now, at least you should have that comfort that we can give. So there should be a space for partners, support, whoever is supporters in these rooms. And as I said, dedicated, soundproof bereavement birthing rooms are the ideal. So, and also the staff. The staff should be available to welcome these parents. So everybody in the hospital should be aware that so-and-so mother is coming for the induction, so-and-so date, so that we should not go and ask why you came. So everybody should be aware why she's coming. And then so that, and also the background, they should go through all the medical notes so that they should not, improper communication should not be there. Ensure that they have read the women's medical notes and birth plan, continuous support and care, which is very important. See, they want to be with someone who is familiar, like, the doctor who is familiar with her or, midwife. So it's best practice to give continuous care and support. Birth companion, obviously. and all levels of staff on the ward should be told about the baby's death. This will help to prevent inappropriate comments, as I told you. The patient board should be marked with a special symbol, for example, butterfly symbol, so that everybody in the ward or coming like staff, everybody, operator, coordinators, and nurses and house cleaning staff, they should be familiar with that butterfly symbol, so that they will understand the so and so mother is birthing. We should be very sensitive, and the support, the need, what she needs is different from others. And all staff should be familiar with this symbol, including administrative, cleaning, and supporting staff. To be sensitive to noise. Example, to avoid shouting and laughing in the corridor. Then offering this support may be challenging for the staff. It's not easy for the staff also to give, this kind of support which they require, but the focus is important from the staff. There is no reward of meeting a healthy baby at the end. So sad. And they need extra encouragement and also the continuous support at least, so that she can cope up with the pain and go through the labor and the birth. Yeah. So when dealing with grieving parents, remember that we are standing on the holy ground. So please respectfully give them support with heart, wholeheartedly, so that she will go through the labor process and then give the birth to the baby. And after the birth, encourage her to hold the baby and leave them alone. Give them some time to grieve, to cry, and be with their baby.
Thank you so much, Dr. Ánitha, for thinking of all the aspects of, the support that we need to provide when such a lady is in labor. But what about the partners and siblings? What do you tell a 4-year-old boy recently who was waiting for a little baby sister to arrive? You tell him the baby sister went to heaven. So the next question, what is heaven? Gone to meet God? What is God? Who is God? Have you ever pondered about these questions, these situations? So we have someone here, an excellent doctor, an activist. Yeah, he's a surgeon. He has gone through some very personal grief experience and is ready to share with us, because all the time we are talking about the mother. So I follow him on Twitter because he's such an activist, always raising social issues. Come on, Dr. Faizan, just introduce yourself.
Very good morning, respected teachers and all my colleagues. Myself, Dr. Syed Faizan Ahmad, and right now I am a senior resident at King George Medical College, Lucknow. जब भी किसी मेल के साथ, मतलब लड़के के साथ कोई प्रॉब्लम होती है, तो वो या फिर अपनी वाइफ को शेयर करता है या फिर वो अपने किसी दोस्त को शेयर करता है. रेयरली अपने फैमिली मेम्बर्स को शेयर करता है, मतलब मदर फादर को, लेकिन मोस्टली अपनी वाइफ को शेयर करता है या अपने दोस्त को शेयर करता है. मुझे याद है कि मैं सर्जरी में अपने कंसल्टेंट को असिस्ट करा रहा था. LPJ का केस था. तो माय वाइफ वाज प्रेग्नेंट एंड एनोमली स्कैन होना था. तो वो उसने अपने मेडिकल कॉलेज में उसने अपना स्कैन करवाया और स्कैन में कुछ एनोमलीज आई. तो मेरे पास OT के टाइम मेरे पास फ़ोन आया जिस टाइम मैं असिस्ट करा रहा था कि कुछ एनोमलीज हैं और मैम ने जिन रेडियोलॉजिस्ट ने करा है उन्होंने बोला है कि एक जगह से और करा लो जहाँ पे थोड़ी सी और बेहतर मशीन हो. तो मैसेज करा रहा था कि तो मेरा उस टाइम दिमाग ब्रेन फंक्शन करना ढंग से बंद कर दिया था. तो मैंने अपने SR कलीग को बोला कि तुम मैसेज कराने आ जाओ, मैं डिवॉश हो रहा हूँ. मैं डिवॉश हो गया. देन आई वेंट टू द सेंटर वेयर जहाँ पे अल्ट्रासाउंड हो रहा था इसका या हो रहा था. मैं सेंटर पहुँचा. एट दैट टाइम सबसे पहले मेरा कंसर्न था कि तुम मेडिकल कॉलेज से सेंटर कैसे अकेले जाओगे, रुक जाओ, मेरा वेट कर लो, मैं आ रहा हूँ. उसने मुझसे बोला कि नहीं, आयशा मैम मेरे साथ हैं एंड शी इज़ देयर विद मी एंड वो मुझे लेके जाएंगी. मैं सेंटर जब मैं पहुंचा ना मेरे पास वहाँ पे मेरे इन लॉज थे, ना मेरे पास मेरे मेरे खुद के मदर फादर थे। तो कभी भी कोई प्रॉब्लम अगर आती है तो ऑप्शन गायनी का कोई केस अगर होता तो मैं उससे डिस्कस करता था कि ऐसा केस है तो इसमें क्या करना है, इसका क्या प्रोग्नोसिस होगा। लेकिन जब मेरे साथ खुद हुआ तो जब मैं सेंटर पहुंचा तो मेरी खुद की इतनी हिम्मत नहीं थी कि मैं खुद इससे पूछूं कि क्या प्रोग्नोसिस है, हमें आगे क्या करना है। थैंक गॉड उस टाइम में आयशा मैम वहाँ पर थी, उन्होंने मुझे चीज़ें एक्सप्लेन करी, उन्होंने मुझे चीज़ें समझाई। आई थिंक शी वॉज देयर एंड शी प्लेड द रोल ऑफ मदर। उन्होंने जिस तरीके से चीज़ों को समझाया तो चीज़ें क्लियर हुई। मैं उसके साथ मैं अपनी वाइफ, तो फिर हम लोगों ने डिसाइड किया लेटर, अब मैंने और मेरी वाइफ ने, कि हम लोग को प्रेगनेंसी को डिसकंटिन्यू करना है बिकॉज द बेबी इज़ नॉट फाइन। हम लोगों ने इस टाइम डिसकंटिन्यू कर दिया बेबी। आफ्टर दिस जो सबसे ज़्यादा और ज़्यादा जो चीज़ पेनफुल थी वो ये थी कि ट्रॉमा था कि हम लोगों ने बेबी को जीन डीएनए टेस्टिंग के लिए भेजा, होल जीनोम सीक्वेंस के लिए भेजा था सैंपल को। देन लेटर फिर हम लोगों ने डिसाइड किया था कि रिलीजियस वे में जो बेबी है उसको ग्रेवयार्ड में जो है लेके जाएंगे आफ्टर द डीएनए सैम्पलिंग। तो आफ्टर 1 वीक हम दोनों एक साथ गए गाड़ी से अपनी सैंपल लेने के लिए, जो बेबी को लेने के लिए आफ्टर द डीएनए सैम्पलिंग। तो मुझे याद है कि जब मैंने लैब से सैंपल को ले लिया था तो पूरे कंटेनर में बेबी था। तो पूरे रास्ते जो वाइफ है मेरी, उसने कंटेनर को हक करे बैठी हुई थी। एंड इट वाज अ ड्राइव ऑफ अराउंड 45 मिनट। हम लोगों ने एक दूसरे से कुछ भी नहीं बोला। वी बोथ वर क्राइंग। जब घर पे पहुंचे तो मुझसे गलती हो गई कि मैंने बोला कि चलो तुम, एक्चुअली जो कंटेनर था वो पैक था, उसमें मतलब रैप था एक, तो बेबी दिख नहीं रहा था। तो जब घर पहुंचे तो मुझसे गलती ये हो गई कि मैंने बोला कि तुम चलो अंदर, मैं बस गाड़ी पार करके आ रहा हूँ। वो 5 मिनट का गैप होगा। जब मैं गया तो शी वॉज लाइंग ऑन द फ्लोर, पूरी तरह रो रही थी। तो उसने रैप को हटा दिया तो बेबी को देख रही थी और बहुत बुरी तरह रो रही थी। बहुत कैसे समझा जाके मैंने कंटेनर को अलग रखा और फिर मैं उसको रूम में लेके गया। पूरी रात यही बोलती रही कि मुझे फिर से देखना है बेबी को, मुझे एक बार और दिखा दिए। तो फिर मैंने बोला कि ऐसे तो पूरी टाइम देखोगे, ऐसे कैसे होगा। मैं अकेला था उस टाइम, कोई भी फैमिली मेम्बर नहीं था हमारे साथ, हम दोनों अकेले थे। और हमें फिक्र इस बात की भी थी कि अगले दिन हमें जाके ग्रेवयार्ड जाना है, हम कंटेनर को बेबी को लेके जाएंगे तो उसको कौन संभालेगा। फिर मतलब बार बार मुझे बोलने लगी कि नहीं देखना, एक बार प्लीज़ दिखा दो। मैंने बोला, हम लोगों ने 2 AM के अराउंड रात को डिसाइड किया कि चलो ठीक है एक बार देख लेते हैं, फिर प्रॉमिस करो कि फिर नहीं बोलो कि हमें देखना है। तो उस बात को लेके मैं एग्री कर गई। तो 2 AM के अराउंड हम लोगों ने फिर से कंटेनर को लिया, बेबी को देखा, दोनों ने खूब रोए। फिर वो मैंने डिसाइड कर लिया था कि पक्की बात है सब सुबह जाएंगे लेके ग्रेवयार्ड, तो फिर प्रॉब्लम होगी, कोई था नहीं, कोई संभालने वाला नहीं था। सोचा कि कंटेनर को लेंगे, उस टाइम निकलेंगे जिस टाइम ये सो रही होगी। मैंने रात फिर अराउंड 3 o'clock के अराउंड ये सो गई थी। मैं जैसे ही मुझे लगा ये सो गई तो मैं 6 AM के अराउंड मैं घर से निकल गया ग्रेवयार्ड के लिए। और अकेला गया था, कोई उस टाइम भी कोई नहीं था जब ग्रेवयार्ड गया। इन्हीं हाथों से निकाला था कंटेनर से और इन्हीं हाथों से वो दफन किया था। थोड़ा थैंक यू।
I'm really sorry for making you both go through all this. And I hope it will be worthwhile because so many people are here who will be providing care to such mothers, and I hope they will know what such a couple, the whole family goes through, and be more compassionate and more sensitive. Thank you so much. We are really, really thankful to both of you.
Dr. Tamkin, can I comment on it?
Sure.
Doctor, I don't think any one of us over here is not crying. We really value your ability to come on and the stage and relive your experience. And it actually exposes all of us to the inadequacies that we ourselves have created and we could have been so much better, so much different. So a big thank you, Dr. Tamkin, for getting us perspective.
So this is one paper that I'll be putting, recent paper, 2024, about the role of parental behavior in perinatal death on the surviving siblings' grief. And I'll be putting that on the group. Yes?
Can I share
Yes,
one
yes, sure.
experience? I mean, it's different from what we were talking about, how to break this news to siblings. I had a patient who had conceived after 12 years. I mean, it was okay, it's accidental pregnancy, but she was very happy. Husband was in another this thing, and her 12-year-old elder son was with her. And he used to accompany her almost whenever possible, whenever school was not there, he will be there with her. Sometimes he will come and hear fetal heart and whatever. She took him to ultrasound also and then showed the baby and all those things. Then as it so happened, I mean, all of us know unexplained part of those stillbirth things. When we had planned her section, it was previous section, and she said, my husband will be coming, and it was 37, 38 weeks. Nothing was wrong in throughout pregnancy. And when the section was planned maybe on Thursday, but she comes on Monday morning with full-term stillbirth. And Monday morning was, say, 7 o'clock or something, and unfortunately she had less fetal movement. All the things which go through, didn't inform doctor, didn't come to the hospital, but we can't blame her. But when she came in the morning, all her relatives, and same, all emotions, one of her psychologist friend or this is saying, doctor, do cesarean immediately, maybe fetal heart is there, you are not, although that drama went through. But what happened was we asked, I mean, everybody was asking when she came to hospital, her elder son had gone to the school, early morning school, 7 o'clock or something. So I think we did cesarean and it was 3.2 kg stillborn baby and all those things. And then we were going through all this process. So the request came to us that, doctor, please wait till the elder son comes. We want him to see this baby. So it was like sometimes we feel ki what should children, how they should be exposed to second pregnancy. I mean, this was a big boy. And he has, I had a feeling that mother has shared all throughout her pregnancy. Her husband was not with her. He was out of station. He was in Bangalore and she was in Pune. And she had shared all happy moments of baby with her son. She even used to tell me, I tell him, whenever the baby hears Dada's voice, baby moves more. So whenever the Dada is hungry, baby is hungry. So that way she was sharing all pregnancy.
Yeah, we all do that, yes.
Yeah.
Everybody is waiting for the next baby to be there in the family, the addition.
But to share
It's
this
very
last
difficult.
moment, that was something I asked her I asked the family how you are going to do that.
Very difficult time. Thank you so much for sharing. So these kind of, these pictures I took from Ánitha's presentation and I just collected them here. We hardly ever see these kind of, photographs being taken once a stillbirth has occurred, isn't it? So these are all from the West. Thinking of all those mothers on Mother's Day, we made this card. A mother is not defined by the presence of a child by her side, but by the love she holds in her heart. So what happens after the birth of the baby? As a senior resident walking into the labor room, I heard a ward attendant telling a bereaved father waiting for his stillborn baby to be handed over to him, look, the labor room is so busy. Should I worry about live babies or should I waste time in handing over your dead baby? So that complete lack of empathy and respectful care for the baby as well, apart from the mother. That is so important. I have seen babies being put in a corner of the labor room, sometimes not even covered, waiting to be handed over to the parents. So please remember, respectful care includes the baby. We now come to the next important part, that is remembering is a form of forgetting.
Dr. Tamkin?
Yeah.
Here. This is Dr. Uma.
Yeah, Dr. Uma.
So, no, I also want to thank Dr. Faisal for sharing his experience with us. But one of the things that he spoke about, which I think we should remember as doctors, is that many times like this, when we send, if you don't have a placental biopsy or an autopsy facility or any, if even when the patient, couple consent for autopsy, we may be doing everything else right. But in many places, they are asked to carry the baby to the center for autopsy. And I think that's really something that is very traumatic. Consenting itself is traumatic.
So we are going to take your inputs about that in the next few slides.
Okay, thank you.
We need those inputs very much. Thank you for that. Yeah.
This is all about parents who wants to see the baby. There are so many in our culture don't want to see the baby, look at the baby. They just want to take off the baby, or they don't want to take the body from the hospital.
Yeah, that's a problem.
How to deal with these things?
So, do we have any evidence what is the right way of doing it? That's what we are going to discuss. Thank you very much for that introduction. Yeah. So, all bereavement care guidelines advocate that for parents be offered and supported in this choice. Well researched what she was saying and what Dr. Uma was saying. But what about us? Do we have any studies, any evidence? Do we know what our mothers want, what our families want? So a lady with previous 2 stillbirths, the common thing is that, the common misconception is that they don't want to hold or touch the baby. And Ayesha gave 2 very good examples, that extremes. Lady with previous 2 stillborns came to me with the 3rd IUFD. Then this time, I offered that please hold the baby. I promise that it will make a difference to her. And when I gave her that baby, that stillborn baby, her reaction was priceless. She told me, ma'am, even after delivering 2 babies, I have never felt like a mother. Today, though I will not be taking my baby home, I feel like a mother. So, though we do not know what is the right way of doing it, what is the wrong way of doing it, but at least we should make an attempt, we should offer, but the thing is, what should we offer in our part of the world? In the West, they have, different ways of memory making, keeping a lock of hair in a locket, something like that. But in our part, in our culture, we don't know. And what happens exactly, before the mother comes back, after discharge, the mother-in-law just, throws away all things or gives away all those clothes, all those memories that have been there. She has been knitting a sweater for 7 months. And then that is given away so that she should not remember. So is it okay to not remember? So because we do not have answers, we are just going through all these changes, learning about bereavement care and trying to know what the patient's choices are. Let's all adapt bereavement care to our appropriate socio-cultural context. Let's suggest, offer, and ourselves also explore till we have more answers. So this is very generously shared with me by Dr. Nuzhat. This is what the Fernandez Hospital is doing. And I think we should all adapt it as one of the best practices, good practices. A bereaved mother is offered this card on discharge with a photograph of the baby. Now, we all know a thorough workup is what Dr. Uma was saying. A thorough workup is needed to establish a cause based on the clinical, story of that patient. So, how to support this decision and the other investigations Dr. Varisha is going to take up, this perinatal workup and fetal, and we are waiting for Dr. Uma's, inputs after her.
Excuse me. मैम एक एक्सपीरियंस मैं भी शेयर करना चाहूँगा. Actually, I am GM Child Health from UP.
Can we just please? Can she just finish and then, because really sorry for that. I know we all want to talk. That was the purpose, and I'm so happy that everybody's talking about it. But we need to finish in time because the next person should not be kept waiting. I think we'll have enough time to discuss.
We all know how important a thorough workup of a stillbirth is. We take a detailed history and a detailed examination is done. Various investigations are prescribed depending upon the indications. However, whatever is the pathway that we choose to work up a stillborn baby, it always ends at two of these most important investigations. That is a fetal autopsy and a histopathological examination of the placenta. But we face so many challenges when asking the parents to consent for fetal autopsy. All the parents have the right to a detailed information of what will happen to the baby and why is it so important. We need to explain to them that fetal autopsy is going to help us to determine the cause and the mechanism of fetal death, especially in the cases where the stillbirth was unexplained. It may also help us identify various concomitant diseases and give the evidence of certain underlying genetic conditions, which may assist in the determination of the recurrence risk, which is important for planning of the next pregnancy. We have to tell them about their options. They have the option for a complete autopsy. And if they're not comfortable with that, we have to tell them that they can go for a limited autopsy. That is limited to a particular organ or an organ system. If they do not want that, they can also get an external autopsy done, which is just getting the weight, height, and various measurements and examining the baby externally. They can go for an imaging autopsy, which will include an X-ray, an ultrasound, or MRI when indicated. Some of the centers worldwide are also practicing minimally invasive autopsy, by which they are using laparoscopic techniques to look at and to examine the internal organs. So we need to tell the parents in a language that they fully understand that it is a kind of a post-mortem examination that the baby will be going through, which will include the removal of the body tissues and the body fluids, which will be sent for further examination. Also, the examination of the tissues will be in the form of blocks and slides. And in spite of a detailed stillbirth workup and a complete autopsy, we might still not have the answers that we need. We need to explain the parents that their baby, except the face, might have certain scars and incision marks, that the baby will not be disfigured and the baby's body and organs will be treated with utmost respect at all times. They have to be informed that there must be need to keep the baby in the storage unit until the facility for fetal autopsy is available, if not immediately. And we need to inform them when we can return the baby to them if they want to perform the last rites or the burial practices. Now, obtaining consent for a fetal autopsy is very challenging. And whenever we obtain consent, it is important we have a written and informed consent, whether it be any gestation. We also require consent if we order a genetic examination. And if we wish to keep those results as medical records, we need to have a consent for it. We need to tell the parents whether they want the blocks in the slides to be returned to them, or they want us and the hospital to arrange for the disposal or the cremation or the incineration. We need to ask them whether they're okay with for us to obtain the photographs of the baby, to obtain the X-rays, whether these photographs and X-rays can be further used for teaching, quality assurance, and clinical audit process, and whether they're okay if these things can be further used for ethically approved research in the ways that can benefit the others. So I would like to ask everybody in the audience, what are the challenges that you face at your institution regarding fetal autopsy? And why is the rate so low despite it being one of the most important investigations in a stillbirth workup?
So Dr. Uma wanted to say something later.
No, I just wanted to highlight that we need to be sensitive about how this transport or this transfer happens if the if the autopsy facility is distant from the place where this birth has happened. Because in many places they don't ask the hospital staff to go and give their issues of billing. There are a lot of little logistics that come in the way, and so the family is handed over and told. So that is something that we just need to be cognizant, because it is very traumatic for them to go. Some of them articulate it, some of them don't. So it's important that we have a process for that also. We are sensitive to the process of consent and telling them and talking to them. But the actual process of transfer, it's not like asking them to take a hysterectomy specimen, isn't it? So it's that is how sometimes staff or even doctors think, because we are not sensitized to handling that bit. I think that's also something to pay attention to. That's all I want.
Thank you so much. Varisha, you are working at SGPGI Lucknow. What is the practice? How is the autopsy done? Is it available 24/7?
It's not. We have so much of backlog, and there's so many babies that are not handed over in time because we are not able to perform autopsy in the time when it should.
Okay, Dr. Bharti, I think you are at Chandigarh. Yeah, Dr. Manju, I would like your input as well. Yeah.
Like in PGI, we have 20, there is a particular time limit, like from 9 to 4, they do the autopsy. But yesterday I talked to the resident who is on duty. She said, ma'am, parents don't want their baby back. So most of the malformed baby, very few she said out of 10, only 3 or 4 parents, they asked for the baby. They just give the baby and they ask you keep it, whatever you want to do.
So it is done daily? When is the baby
yes, it is done
ready
daily.
for the last rites?
Yeah, it is done daily. There is some time. They'll call after 8 hours or after 7, but they have to wait. The family members have to wait. It is not like stat.
Okay,
they
Dr. Manju.
No, what I was trying to say was that from the sharing which we had, that we need to be very sensitive about handing over and the burial time as well. I'm saying we don't pay any attention to it. What are they going to do with that baby, once it is handed over? We just want to finish our work, especially in high load facilities, So you just hand over and finish off with your work. So I guess that is very, very important, and lot of insights and lot of perspective has come. We've never thought of what happens once the baby is handed over. What are they going to do with that?
Yeah, so it is not available 24/7. It's a problem. So much emotionally draining. I'll just finish. When I lost my daughter 2 years ago, they kept her in a regular refrigerator. Not only that you lost her, but also stored her in this way. This is really terrible. So this person thought of keeping the baby with the mother. And this is a cubitus baby, an innovation giving time for saying farewell, that's lined with ice packs, and the baby stays with the mother. So nobody would want this situation to happen with them, but again, this is something better rather than just wondering where your baby is, or baby is lying in the refrigerator all alone. So very, very quickly, a few inputs. I think Dr. App, you wanted to say something? The one,
Actually, ma'am, I want to draw attention on two intra-procedural points. 6 months back, जैसे अभी डॉक्टर फैजान was sharing his own experience. तो कुछ ऐसा ही मेरे साथ भी हुआ. मेरे एक इन-लॉज यंग ही थे दोनों के, को मेडिकल कॉलेज में उनको पता चला कि एनॉमली से ये फिटल एनॉमली है और इसको अब टर्मिनेट ही करा देना बेटर होगा. तो सब कुछ ठीक था जब मेडिकल कॉलेज से उनको परमिशन भी मिल गई. एंड जब वो टर्मिनेशन कराने गए तो वहाँ पे जो चैलेंजेस आते हैं, शायद मुझे लगता है कि हम उससे आगे की भी बात करें, लेकिन वो प्रोसीजर के दौरान जो चैलेंजेस हैं कहीं ना कहीं उनको भी एड्रेस किए जाने की आवश्यकता है. जो माई वाइफ इज़ ऑल्सो डॉक्टर एंड सी इज़ पैथोलॉजिस्ट. तो प्रॉब्लम ये थी कि उसके कजन थे और उनकी मदर वॉज इल और वो बेड रिडन थी एंड फादर वॉज नो मोर, एंड सपोर्ट करने के लिए कोई फीमेल नहीं थी. एंड जो उनकी वाइफ थी, जब उसको ले जाया गया, बहुत कम एज थी, करीब 22 to 24 ईयर्स की रही होगी, उसको जब ले जाया गया अंदर एलआर में, लेबर रूम में, जहाँ पे एक सेपरेट इंडक्शन रूम था, तो वहाँ पे कई सारी इस तरह की औरतें थी, फीमेल्स थी, जिनको इंड्यूस किया जा रहा था. एंड सडनली 2-3 फीमेल्स ऐसी थी जिन्होंने मतलब एक दो तो वो शायद एक्सपायर भी हो गई उस प्रोसीजर के दौरान, एज सी वॉज टेलिंग. तो सी वॉज वेरी नर्वस एट दैट टाइम. और बार बार जो रेजिडेंट्स एंड जो वहाँ का स्टाफ था, दैट वाज नॉट कोऑपरेटिव. मतलब वो इस तरह से ट्रीट कर रहे थे लाइक कि क्या हो गया, क्यों आ गई ये यहाँ पे. तो कहीं ना कहीं इस चीज़ को देखना बहुत ज़रूरी है कि ये जैसे आप लोग बात कर रहे हैं, बड़ा एम्पैथी एंड सिंपैथी की ज़रूरत होती है उस समय जब वो एक ऑलरेडी एक मेंटल ट्रॉमा से गुजर रहा है. और बार बार वो कहें कि किसी फीमेल स्टाफ को भेजिए, मेल स्टाफ अंदर नहीं जा सकता. उसका हस्बैंड भी बेचारा, वो भी 26-27 साल का था. एंड ही वॉज रेडी कि हमें आप अंदर ले लो, हम अपनी वाइफ का टेक केयर कर लेंगे. बट उनके पास कोई ऐसा ऑप्शन नहीं था और कि वो फीमेल को भेजे. फीमेल उसकी मदद. तो एक वन पॉइंट दिस एंड अनदर पॉइंट. दूसरा ये था कि जैसे फादर्स, हम लोग बर्थ कंपेनियन की बात करते हैं, अगर हम इंडक्शन कंपेनियन भी एक इस तरह की चीज़ रखें तो शायद बेटर होगा. और दूसरा ये SBCC जो हमारा स्टाफ जो प्रोसीजर कर रहा है, उसके सोशल बिहेवियरल जो कम्युनिकेशन की स्ट्रेटजी है, उस पर भी हमें कहीं ना कहीं बात करने की आवश्यकता है. तो ये दो पॉइंट्स पे आप लोग अगर बात करें.
Thank you so much for highlighting those points, and we'll keep that in mind. And now Dr. Bharti is going to talk about mourning and burial practices. We have, I think, 35 minutes more.
Okay. So now this topic is not very few evidence is there. So I try to find out what actually is and what we have. So how the funeral of stillborn is different from a lightborn or an adult? Any idea? In India, Hindus, they traditionally cremate their dead, whereas Islamic customs and Christians, they emphasize on burial. The person's loss is then accomplished through rituals such as cremation, disposing of ashes, or burial, or placing tombstones. In all religion, whatever it's a Hindu, Muslim, or Christian, they always pay or offer prayers for the forgiveness of the dead. So what is personhood? I was just searching why we grieve, why we think about a person when someone dies. So they say that there is a doubt, there is a provisional personhood of a fetus in utero, basically. If we read about some Islamic studies, they have written that कि जब quickening होती है तो रूह आती है baby में. They consider baby live when a mother feels that there is a quickening. So basically, when fetus is inside, it is a provisional personhood. And it is not a very full personhood that baby is going to survive. So the nature of mourning and degree of ritual elaboration depends upon the importance of that person in society. In Andaman Island, they say that they cry more for adults. And when there is a death of some young ones or infirm elderly, they disposed of with scant ceremony. They say that person was not for that importance. That's why there was less grief and less rituals, and that's what the thing is that. So it means that a live birth is necessary for loss of socially recognition. So if we look at any religion, whether it's, there is always a viewing or wake. What is viewing or wake? That is the saying goodbye to our dear ones just before we either cremate them or bury them. It is everywhere, irrespective of religion. So why they do? There is a scientific evidence, just before, sending we say goodbye, right? Similarly, after death also, this is just to make them real that, see, that person has gone. Now it will be easy for them to grieve and understand, yes, my near one, my mother, father, now he's no more. So we need to understand. So it is recommended that the bereaved relatives view the body to provide a sense of reality about their death, to say goodbye. And it is considered scientifically also, it is considered a good practice to make it real. But in India, there is a burial of stillborn. I was searching in literature. It is combination of legal, cultural, and religious practices. There is a registration and documentation, but we all know what kind of documentation we have for stillbirth. That is the problem. That's why we are here and we are discussing stillbirth separately. And funeral procedure as per the religion or the parents' wish. There in Hinduism, they have used word. If you ask any of your mother or grandmother at home, they'll say that it is simplified as compared to the live births or adults' death. Similarly, for Islam, they say they recommend that there should be prompt burial. That's why there is a problem in counseling such parents for autopsy, and they are buried without elaborate rites. I was talking to one of my patients.
she said, Madam, हमारे जनाजा नहीं निकलता because बच्चा stillbirth था. Similarly, for Christianity, what I got through the literature, they said that before baptism, they don't consider that person. So that should not be having the same kind of ritual we have for adults. So what are the implications for recognition of child when a pregnancy is lost? So it's in news. If you search through, there are many papers. It is in 2007. Just look at the year wise. This I got the oldest one. In 2007, when Commonwealth came, there was a things around to clean the Yamuna. So in this newspaper, they have interviewed the person, and what he said is, in Yamuna River, there is a small patch of land by the river covered with weeds and human and animal feces, is popularly known as Bacche Wala Ghat or child burial ground. It's been the person who is working there for the last 40 years, he said that our religion says that baby cannot be cremated. They have to be put in the river or buried. People come here from all over Delhi. So there was some issues, and there was some court order also that they should have a proper burial places. So then what that person has told in that interview, the court order has obviously made no difference. Which mother wants to burn her little one? When a child suffers a small burn, we take it to the best of doctors. The government will have to make some alternate arrangements. Kishore, that person's name, who lives in a dusky shack of river, takes the baby covered in a shroud to the middle of the river on his boat and says a short prayer and slips them into the water. Their bodies are tied with bricks so that they sink. That is what is in our, I got. So there was after this in 2007 only, there was a no safe burial for kids below 3. So there was some statement by the government to provide a safe burial place for the kids, because normal crematorium ground or burial places, they are not allowing that kids to be, buried there. So after so many years, I got this news it is in 2021. There also it's a Christian baby. They were shocked when the priest declined, saying that he would neither bless the child or conduct the funeral rites as the child was not baptized. And this news is in 2022, where man held after video of him throwing stillborn baby into river in Srinagar goes viral. And when he was asked, he said, he told to the police that his wife had delivered a stillborn male baby, and to save the inconvenience of carrying the dead baby back to his native place, he tried to dispose of his body into the river. And this is the latest news in 2023, where again man dumped stillborn baby in Chennai's river. And here also, man told his relative that he had dumped the child in a river as he did not have money to conduct his last rites. So this is the scenario which I got from our country. And this is also in newspaper, where this baby was a 460-grammer baby. It is in newspaper. And this baby was handed over as a stillborn. It was a controversial case where baby started moving and, but this was the condition how baby was handed over to the parents. Now just look at UK, what they have. In UK, burial or cremation of a stillborn baby or infant is required by the law. If the baby was born after 20 weeks of pregnancy, and if baby is born before 24 weeks, funeral is not legally required, but it can still be had. They have beautiful graves where they, go and spend time. They have such kind of places where they go and, remember their babies. But most of our mother have no memories of their babies, except they just remember that they went into labor, and that's it. Now I would like to ask you, do you know any mourning practices? What people are following? What is your experience about mourning practices? What are they doing after burying their baby? What are they doing at home? I have recently conducted a study with Dr. Neelam in Haryana district, and there those women, one of our families, they told that every day they go and visit that place where they have buried that baby, and every day they go and pour milk to their baby. For 7 to 10 days, they go there and pour milk. And few of families, they bury all the clothes with the baby. whatever they have bought. That's why in our North India, people don't do any shopping before the birth of the baby. They feel that it is not a good sign. They just wait for the birth, then they do the shopping.
Hello, I'm Dr. Ashwini from Maharashtra. I am practicing in rural area basically, not exactly rural but town. So what I have seen at our places when there is any stillbirth or any when we terminate such anomalous baby, usually people take that babies to their farms or nearby farms known to some person. They bury the bodies there and plant a tree over there, and they worship that plant every yearly or in some during some occasion. They offer some offerings for to that plant, and they grow it they take care of that plant very well. Actually, whatever, as I'm in rural area, that's why I see these kind of things. I think the scenario may be different in urban area.
Okay. Dr. Dasari.
Thank
can we
you.
just, yeah, be
Thank
very
you.
fast?
I'll
Yeah.
be very short.
We
So I am from South India. Throughout my life, I just retired. I worked in one hospital in South India, which caters for a large number of deliveries, that is JIPMA. So the practice there is that people don't agree for autopsy, especially when we offer for unexplained stillbirth, because of the religious practice, which is just highlighted, because they want to bury the baby, especially Hindus, without a cut on the baby. This is one thing. The other thing is, in the hospital, even if somebody agrees for autopsy, there are no facilities. The pathology department just refuses. We don't want to do fetal autopsy. We are not trained in that. This is the second, and what to say, it is a hurdle to get an autopsy done for unexplained stillbirth, because medically also it is important that we offer autopsy. So as Dr. Uma said, we have to transport to other centers like Chennai, somewhere where even for congenital anomalies, we do transport to Mediscan Chennai when we want to get the diagnosis. So what I want to put here to the August organizers is that the government of India has to form a policies that, especially in the institutes of national importance, I don't know what is happening in PGI, Chandigarh and New Delhi, they do autopsy. I have attended one of the meetings where they discuss the obstetricians and pathologists. So it should be a mandatory from your side that you have to put autopsy, fetal autopsy should not be refused in a public sector. Yes, your inputs out of this conference, I feel it is essential.
So the purpose of all this whole discussion was, I'm very happy that you emphasized two very, number one, this whole discussion brought about two important points.
And another thing I want to put forward is that a place for bereavement where the birth companion, first of all, birth companions are not allowed into the public sector hospitals, because I did a project. And there was lot of what to say, opposition.
So what we can do is that you can
finally I could achieve that birth companionship is mandatory in our hospital.
So we can put all those, can you just put all those points
and
in the group?
Yes,
in the group,
and
so
a
that we can make
bereavement room
a
is
summary of all the
essential.
suggestions. So
Yes,
that will be
ma'am,
very helpful.
You can put this up to the government of India.
Yeah. So can we just sum up the important points that emerged? Dr. Neelam, may I have your attention, because this is something very important that everybody has brought about. Number one is that we have different ways of, the last rites. So as doctors, we should be aware of different religious practices. And sometimes the patients themselves, they don't know, and then they come back after some time. I think Dr. Neelam has recounted that incident, that patient came back after 2 years or something. She wanted the photograph of the baby, and
actually this was my own niece.
Okay.
And hydrocephalus somehow was diagnosed at 32 weeks. Very highly educated girl working in a high MNC IT sector and all, husband also the same. So the thing was that mother was very, very dominating for this girl, and she never let her grieve for this pregnancy. She said, okay, it's nothing. So like that, the pregnancy continued till 38, 39 weeks, and then she went into labor, and we did craniocentesis and delivered her vaginally. So I just took this girl aside and I asked her, if you want to hold the baby, see the baby, I will let you see the baby, hold it, and you can take a photograph or whatever you want. She says, no, I do not want anything, because her mother had put it into her mind that this, if you see baby, you may not have another baby normal. Just look at this girl who's means earning so much and such a bright girl. But she didn't agree. She said, no, Mami ji, I was means her Mami in North means it's a maternal aunt from the husband's, from the father's, mother's side, right? So she said, no, I do not want to see the baby at all. Please do not show it to me. So I just thought that she knew her psychology. So I just covered the baby. We put the clothes and everything, and we took a photograph, and I kept it with me. I never disclosed to her that I have this photograph. But I just conveyed to her mother that I have the photograph of the baby. If anybody wants to see, I can send it. And by chance, I kept it saved on my laptop. So after then this girl, she could not bear this grief, and she settled in Canada. And there maybe she changed her mind and everything. So once her daughter was born, after 2 more years, then she asked me, do you have that baby's photograph still with you? I now want to see. So this is
thank you so much for sharing that experience. So what needs to be highlighted, that we should know the different religious practices where we are working, what is the usual practice there. And also, because sometimes one patient came to me, said, Dr. Sahab, aapne nahi bataya that the baby was more than 24 weeks. I should have given that baby a proper burial. You didn't tell me. So we should offer them, or at least put those papers at the website. If they themselves know what to do, let them go ahead. One of my Christian patients, they refused even a placental examination. They said they have to bury the placenta. So we should know what is prevalent in that particular population that we are serving. And a very important point Dr. Dasari highlighted, that we need to have more trained perinatal pathologists. Now, the death is not the end. Follow-up after stillbirth delivery. I think most important point here is that when you try to find out what happened, it helps in closure. So that is most important that we should be following. And whenever the patient is being discharged, death certificates and audits, they should be expedited. Everybody should be aware and not keep the patient unnecessarily in the hospital. And in the UK, they have baby loss certificates that has also been launched as part of grief. Recognize the parent's grief. Maybe it will take a long time for us to reach that level. Accountability. Should the accountability be, established, or should it be a confidential audit or inquiry, or should we involve the parents when we are auditing or establishing accountability? Because medical errors do happen. And what is better, to tell the truth or to just give them a false statement? So again, evidence proves that they are happy to know the truth even when you have made a mistake. It is best to admit your mistake. And this I already discussed, to involve them in perinatal mortality review, because this gives them more confidence in your system. And they know that they find it very welcoming that they are being involved in trying to find out what is the cause of the death. So evidence also says that parents, they feel happy about being involved. So now coming to the last and most important part, at the heart of it all, what matters most is who has touched our lives and whose lives we have touched. As doctors, we all believe in that, and that is why we become, better doctors, more humane doctors. So Ayesha, can you just take over from here?
Ma'am, I would request you to stay on the slides, please.
Okay.
So the next topic that we're going to take up is, how do healthcare workers cope up after having, a patient with stillbirth? So I would like to have experiences from the audience. Anyone, please. Most welcome.
So anybody remembering not to, sleep the whole night because something like that happened? I've heard Dr. Nusrat talk about it.
So I remember, and I would like to share my experience. When my sister, she had a stillbirth, I was also involved. You know, I was not the obstetrician. She was delivering at some other hospital. But then after that, I was taking care of her. And it was so difficult being a sister and being a doctor at the same time. Very traumatic experience. And, you know, I didn't know whether to tell her about the baby or not. How to tell her about the baby. She developed, when she learned about the baby, so she developed ectopics, so much so that we had to do an angiogram for her. And then she was on medication. That was, you know, such a traumatic time being a doctor, you know, breaking that news for so many nights. You know, I also couldn't sleep. That was, you know, but then when you see patients, you know, some patient has come to you, 9 months she's been there with you, and suddenly how to face that patient that it's a stillborn baby. Anyone would like to share their experience?
They experience what they have gone through,
Yes.
and we are doing truth and dare.
Yeah.
You can even say sometimes, you know, because most of the time we don't
Yes, ma'am.
accept our mistakes. How do you feel when you know something has happened because you were busy, you were not well, or your mind was preoccupied? And
I had a patient. This was like, you know, she's a chronic hypertensive, conceived after 8 years, second pregnancy, 8 years of married life. Because I advised her like induction at 37 weeks. She said that day was not good. She wanted to come 2 days later. I told them that it's better to get admitted. Then her mother-in-law and mother said, Ayesha, not good. Please consider 2 days. Her blood pressure is normal. Her NST was normal. Everything is normal. Why? What will 2 days make a difference? I don't know why I gave it to it. I said, okay, come after 2 days. She was supposed to come in the night for the induction. That day morning, she landed up with full-blown abruption, HELP syndrome, everything. 2 days later, when all the reports, and then it is like, you know, why did I give in for that stupid discussion of Muhurtam? And that haunted me because it was a healthy 3 kg baby lying there still, just like, you know, abruption. She delivered fast because it was an abruption, vaginal delivery. But thing is, it was so fresh. Just 2 days. I couldn't sleep for so many days. Why did I budge in? Like, you know, telling them because there was no IUGR. Then again, we think about it. 37 weeks, 2 days, what might happen? No, most of the patient, nothing will happen. But this patient, because she was married for 8 years, attenders was so much this thing on the whatever days they wanted to deliver, but then landed up, and it was, I mean, couldn't do anything because seeing that fresh born, it was bad.
so has anybody ever cried in front of a patient? Any one of you?
And
So many.
ma'am, what help did you get? Did you get any help from any colleague? I mean, how did you get over that trauma? Did you, so like in...
Also, the second patient was breech. That day itself, I did an NST breech. We planned for a previous normal delivery, external cephalic version and section was discussed, 36 weeks, planned at 37 weeks. Next day morning, she came with, madam, till night, baby was moving. Now I feel it's not moving. Then I said, okay, yesterday evening, beautiful
So
NST.
we want to...
Sudden NST, cord accident. Thing is, the same. Again, how you discuss the 8-year-old child, where is my brother? The same discussion on. So getting over this was so difficult. Till now, I don't think I got over it.
Okay, so we want to listen to what you felt
can
rather
I-
than the story of the patient.
Can I just...
It's more about healthcare workers, yes.
So basically,
definitely.
you know, I had a patient, I still remember her name, Anju. So she was she was primary, you know, and she was not primary, she was a previous cesarean, and she was undergoing induction. And everything was okay. So I examined and went, and that was 31st, I still remember, New Year's Eve. So, she was 4 centimeter active labor, so everything was going on well. And I got a call, I was a consultant on call, so I got a call that rupture uterus. And I came in the middle of the night, operated. So, it was a dead baby. It was so traumatic, there was no system I could, kind of get myself out of it. Half the time I kept thinking that, was it okay to give her a trial because she was previous cesarean, and a whole lot of things. So, till such time she had another baby, those 2 years, every New Year's Eve, I would not, I would always remember. So I think it is essential that we have some kind of a support available for the healthcare providers. We don't understand, that, how much trauma they go through, especially the residents. We as consultants would kind of outrightly, tumne ye nahi kiya, you've not done this, blame game. No one would do it intentionally. And I remember one of the girls crying in front of the patient attenders, because they had come with a complaint, so I made her sit and she was crying. And the attenders also could feel that, the doctor also is in so much of pain. So I think that part is missing, from us. I think everything is missing. If you really ask me, all what we have done today, we are hardly sensitized to what happens and what we are not trained. And I'm so great that we have had this workshop and we are at least thinking every facility should be stillbirth compliant facility. I think that is what we should look at. It should be a kind of guidelines we need to come up with. And we must make sure that we support all levels of care and all victims. This is the first victim, second victim, and the third victim is the doctor. And
so we are I think, the first victim because we are the one who, who knows the news first.
Absolutely.
Sometimes you just don't know how to face the patient, and then you suffer from, loss of self-esteem for such a long time because you keep on blaming yourself. Yes, Dr. Vita.
I think all of us suffer from guilt. Even if you feel you can't explain it, you're still asking yourself, could I have done something else? So guilt is definitely something, and we carry it to our graves. The Mayo Clinic, one of the physicians said, all of us have our graveyard stories, which means we carry these to our graves. The second, when you're in a leadership position and you have an IUFT, it's even more difficult because you begin to question yourself, am I losing it? Am I competent? And fortunately, at Fernandez, we support each other. And I think that's so important, that we reach out to each other when we have a problem, so that person is not alone. And recently, thanks to Indy, we had a death. We had a maternal death, actually, some time ago. And she raised the thing of the need of having a psychologist. And we had a counselor come in. And that helped the staff, the nurses, the doctors, because everybody was grieving, feeling terrible about it. So I think the time has come when we need to watch each other's back, be there for each other, support each other, and also bring in the mental health issues for us healthcare workers. That needs to be addressed.
I think very nicely put. Can you just note down those?
And maybe
I want it here.
Madam.
So one was stillbirth compliant facility.
That's a
The
wonderful
system
idea.
should be supportive.
And
Yes.
has anyone
I want to
faced-
speak, ma'am.
Yeah, ma'am. Has anyone faced any aggression?
I want to speak on that. I'm Dr. Srilila. I'm practicing from 2001, ma'am. And after many cases, I'm talking about the recent case. I have had many experiences, but the recent one was she was around 37 weeks. She came with history of fever on the previous day. We had done a CTG and we have given treatment for her fever. She went back and she went to the government hospital first with loss of moments. I didn't know about the story. Then she came to me as a regular patient. I saw her, it was an IUD. I had done a scan myself, and then I called a radiologist, and he had also done. I sat with them. Only the mother and the patient had come. For 20 minutes, I had consoled them. We are always soft, and first we are always guilty. I have done something yesterday. I should have done something. All these were running. For 20 minutes, I have consoled them. Then casually, I wrote CBP, platelet count, PT, APTT, and I sent. I told, I'll just have my lunch and come. I just told them, that's all. And my house was at a different place. I had to go, I had to cook, I had to eat, and I had to come. It was 1 hour difference. By then, her husband had come. I got a call. That delay and my submission, we are always, very commonly we tell, they were so aggressive. How could you eat when my baby was like this? How could you go to your house? From 6 o'clock in the evening to 12 o'clock, there was a massive, they called the whole village, and 100 people had come. We had told the police and all, everybody had come. And the police are like brokers. Till 12 o'clock, they didn't manage. And they were asking for money, everything. So we should always get another picture of this.
So I'm sure many of us have witnessed these scenes, not directly, then indirectly. We have some very seniors, sensitive people sitting here, Dr. Vita, Dr. Manju, Dr. Neelam. We want some inputs. How to deal with such a situation? Anybody?
We should not
some
tell
inputs
them
from you?
anything.
Yeah.
We should be there. We should be there always.
So that is one lesson. How to...
Hello.
Yeah.
Hello.
But please, we have just 3 minutes remaining. Yeah, I want to finish in time. No, we have few more slides as well. Yeah. So we don't break the news alone. That is one point. Yes.
So
Yeah.
we also we teach and we like to be very truthful.
So another is being truthful. Yes,
I think
definitely.
truthfulness
The
makes a
patient
lot
really
of difference.
they appreciate that.
Yeah, they appreciate it. And sometimes, we've had good experiences coming out of this. We've had a stillbirth. There's been an angry mob. We've gone through the press. And we've had to give public statements saying this is what we have. I think documentation is extremely important.
So documentation is very important. One input from you, just one, please. We will.
This is regarding.
We don't want to overshoot time.
This is regarding feeling guilty. See, in our philosophy, it is written that any act, any work to be done, there are 5 things which are required. अच्छा place चाहिए, अच्छा surgeon चाहिए, अच्छा instruments चाहिए, and different methods of doing it, protocols. So ये सब अपने किया है, तो 5वां fate है, वो अपने हाथ में नहीं रहता है. Cord prolapse हो गया, अपने हाथ में नहीं रहता है. So try and improve upon all these 4 things in your life, so you will not feel guilty. जो होता है अपन नहीं कर रहे हैं.
Absolutely
अपन
right.
सब कर रहे हैं.
Yes.
So I'll just say the sloka in
follow guidelines, protocols. Yeah.
अधिष्ठानम तथा कर्ता करणम च पृथक विदम विविधाश्च पृथक चेष्टा दैवम चैवात्र पंचमी. 5 things are required. जैसे मैंने बोल दिया अधिष्ठान वगैरह ये सब. So ये अपनी philosophy है.
So can you please put that on the group? We want to and translate it as well.
Sure.
Okay, thank you so much. So it is not
Just,
acceptable to
one
grieve for all
input,
of us.
One myth is that whenever IUD occurs, the peripheral health doctors will say that it has to be delivered immediately, otherwise the mother will die. So this is a myth. That may be the,
So
yes.
they will have
so
a
that
whole
needs to be corrected.
Yeah.
That is
We should
why the
explain
mob
to
will
them,
come, because they think that
Absolutely
it has
right.
to be delivered immediately.
A small submission, madam. Any high-risk pregnancy we are dealing, better you take the support of your own colleagues, or it should be intimated to all, where the leading doctors can come and attend. There will
The
not be
senior
any
most
problem.
doctor, yeah, you're right.
Thank you.
So what I wanted to say here, that all of us need training in bereavement care and access to supportive care, counseling or debriefing sessions. And we should all remember it is okay to be not okay after the death of a baby as a healthcare worker. So look after your patients, look after yourself, and look after each other. Talk, discuss, debrief, ask for support. Whatever you're going through, you should not be going through alone. Any questions for future research? I wanted to discuss with you, but there's not enough time. You have just, Bharti, okay.
Ma'am, I just want to add why we talk good only with the patient. We should talk about the stillbirth since the day UPT is positive. She should be knowing
Absolutely
that
right.
yeah, that is the most
important
thing. The very first day we should tell that this is the stillbirth rate of India. In spite of adequate care, there is some chance of stillbirth.
When we talk,
I think, because we
Bharti,
can't give 100%.
the research says that the most important thing that the parents, research has proven that the most important reaction of the parents is that they never told me that outcome of this pregnancy any pregnancy could be stillbirth. Can we move forwards? Talking about future, Dr. Nuzhat will really, and you'll miss the next, is workshop. We all want to attend that. So have you seen this movie? Rudali, yeah, you can recognize. So in this movie, they have professional, and it's based on true facts. In Rajasthan, they have professional mourners. So to just manage their grief, they have made it into a celebration. So in a country like ours, where grief is taken so differently, with so many religions, so many cultures, so many regions, it is so difficult to arrive at what is best or what is evidence-based. But when we keep working on it, I'm sure that we'll be able to give the best to our patients. So these are known as Rudali or tear sellers of Rajasthan. Delivering bereavement care sensitive to social cultural practices helps you graduate from empathy to interpathy. So as doctors, not just about empathy, it should be interpathy for all of us. So we will all get a certificate for attending this right now, but there is a test which follows. We'll be notifying you in the group, and if you complete that training part online, we will also give you a training certificate that you are one of the trainers of trainers, and you can carry forward all this work in your respective regions. So thank you very much. An invitation to join the Stillbirth Society. These are the consensus statements, and a big thank you to all of you. Thank you for that very interactive, that experience sharing. We have noted down each and every, your perinatal pathology training, everything, all those inputs that we have received. Thank you so much.